why do we want to do a rapid EEG? And what you can see here on the left in the orange chart is really just a graphic showing that the longer a seizure goes on untreated, the less likely it is to respond to the first anti-seizure medication. And that's particularly important because on the graph on the right here, what you see is the longer a seizure goes on, the higher the morbidity and mortality of the patient. More recently, for 2022, the Joint Commission has changed their requirements, which is very interesting. And my team is working on making sure that we follow all of the new guidelines. The requirement is that for all cardiac arrest, post-cardiac arrest care, that you align with the 2020 American Heart Association ACLS guidelines. And what do they say? They say comprehensive post-cardiac arrest care is necessary to address the systemic effects of the ischemia reperfusion injury following cardiac arrest. So, yes, even I stumbled over that big long. What does that mean? They recognize that it's critical for patient survival and for optimal neurological outcomes if we follow these guidelines, these evidence-based guidelines on the right. So for either a nonverbal or awake alert patient, they recommend EEG monitoring. But, you know, people have also asked me what really matters to me as the chief nurse and the chief operating officer. And I always say that the very most important thing for me is always patient care. And as I mentioned, we knew we were missing seizures because we really couldn't get access to it. And we wanted 24/7 access, but with smaller hospital, it doesn't make sense to have an EEG tech, you know, sitting around waiting for maybe, you know, that one EEG that might occur during their shift. We knew we needed ED coverage, but again, it was really hard to justify. Not only was it hard to justify an EEG tech, but it was hard to train one. As a matter of fact, I had a respiratory therapist at the time who was very interested in learning EEG. And we spent several $1,000s to send this tech all the way to North Carolina to get a 2-week training for EEG. And just to find out about 8 months later, she left us for another organization. So that didn't work out so well. So we knew we had some troubles there. The other area that was so important to us is length of stay. And we knew if we had patients waiting around for EEGs, it was likely impacting our length of stay. At Common Spirit Health, for those of you listening who are with Common Spirit, it's so important length of stay that there is a new directive that the C-suite needs to attend our discharge rounds, or here what we call them as our multidisciplinary rounds. And those rounds occur every day, Monday through Friday, with our care coordination team, with our physicians, with our bedside nurses, charge nurses, social work, and many other folks from the multidisciplinary team. And the whole point of that is, where is the patient in their stay, and what are the objects or issues that might be stopping their discharge? What needs to happen? Do they need physical therapy? You know, all of this multidisciplinary team comes together and talks about how do we get this patient safely to discharge. And, you know, it's so important that they've mandated that, again, the C-suite be there. For my role, I need to be there at least twice a week. The hospital president is expected to be there at least once a week. The chief medical officer is expected to be there twice a week. And more importantly, I think the impact of length of stay on our bottom line is so important that our CFO is expected to be there twice a week.